So, spinal cord compression. So this is a medical emergency, and it could actually mean the difference in someone being able to walk or just being completely paralysed. So it affects about 5 to 10% of cancer patients, most commonly in the tumour sites that I've listed there. So I see quite a lot doing lung as well, breast, prostate, and the actual haematological malignancies as well. And actually 20% of patients actually present with spinal cord compression as their first, touch base, with a cancer diagnosis. And the mechanisms I've written there, so either a hematogenous, so that means cancer cells going in the blood and sitting in the vertebral body and growing, okay? Or you can have a pathological fracture of the vertebral body, which is just completely infiltrated with tumour, and that results in cord injury from bone fragmentation and instability and retropulsion, and I'll show you that in a minute. 65% affect the thoracic spine of cases. We do see lumbar spine and we do see C-spine as well. But as I said before, it's a medical emergency. So the first symptom is spinal pain. I appreciate you see a lot of patients with back pain in the community. 90% of patients complain of pain for weeks, and then they suddenly get neurological compromise. So the pain can change characteristics. It can, escalate, so a crescendo-like quality. Patients who have C-spine lesions can have what they call Lermite sign, which is an electrical sensation which runs down the back into the limbs. I haven't seen that very often, but it is reported. And then one thing I didn't put on here when I actually looked back over it is night pain. That's really, really important. If the patient is getting severe night pain, then that always makes my head and alarm bells ring in my head. So as I alluded to earlier, as the tumour expands and the capacity to accommodate it within the spinal canal is exhausted, then you get rapid neurological damage. So different types of pain: root pain, severe and sharp, radiating around the dermatome. So patients may say back pain is coming around a bit like a band, and it's worse on movement and also at night. Then they describe segmental pain, which is a continuous deep aching pain. It's not affected by movement. You always ask about problems with bowels and waterworks, and the sphincters are normally well preserved initially in spinal cord compression, but that can be different in cauda equina, which I'll talk about in a minute. And then if it's a cord compression, you often see upper motor neuron signs when you assess a patient clinically. So weakness, hyperreflexia, clonus, spasticity, and then extensor plantars. In cauda equina, so what we're talking about now is compression of the horse's tail. So if you imagine the cord comes down to about L1, L2, and then it divides into that little horse's tail that comes down. So it's compression of that, okay? And you can see some kind of strange flitting kind of neurology with that. It's often quite difficult to determine. You get saddle anaesthesia as well, and you get typical problems with the sphincters, so bowel and bladder problems. And here you have lower motor neuron signs, so a bit different, obviously, to the cord compression. So you're looking at weakness, wasting of muscle if it's been there for a while, absent reflexes, hypotonicity, fasciculations, and flexant or absent plantars. So nice guidelines on cord compression. I've picked some of them out to show you. We've talked a bit about the symptoms suggestive of spinal metastases here, and here nocturnal pain. That's important. And then also some of the signs here that we look for. And as I said earlier, that just over 20% have no previous cancer diagnosis, and they attend and that's it, and they've got horrible disease. 95% have pain. 85% have weakness at presentation, but actually nearly 20% of patients just walk around and they're absolutely fine. So they're the ones you want to get treated as soon as possible because you want to keep their power. Okay. So in terms of how we do it to investigate it, I think X-rays aren't actually recommended. They don't show anything. So I've had a number of patients who have had lumbar spine X-rays, anterior, lateral. You can see that the vertebral bodies are fine. They're all in alignment. It looks fine. But actually, looking at the MRI scans of those patients that I've seen before, they look awful, and they've got fulminant cord compression there. So NICE don't recommend doing X-rays. What you need to do is an MRI scan of the whole spine. Obviously, if it's contraindicated, they've got a pacemaker or metal or something in their body, then a CT scan will suffice, but MRIs are much easier at looking at things in more detail. So if the patient, arrives to the hospital in acute oncology with query core compression, we like to try and get the MRI scan done within 24 hours. It's a bit difficult sometimes if you've got one MRI scanner in the hospital, but it is a medical emergency. And MRIs are actually very sensitive and specific for core compression. And the reason why you do a whole spine is actually, nearly 20% of patients have 2 levels of core compression. So it seems silly if you're going to be treating one down here and then actually later on they have something else higher up here. So that's why we do the whole spine. So the next thing I want to talk about is superior vena cava obstruction. This again is a medical emergency. It's due to extrinsic compression, thrombosis, or actually direct invasion of the SVC. And actually malignancy tops that list. It's quite a high cause. I see quite a lot giving lung cancer, so bronchial carcinoma, lymphoma as a cause. Also, if you've got any central venous access devices, that can sometimes cause complications. And also you've got your germ cell tumours. So the symptoms and signs here are, facial and upper limb edema, dizzy and, syncope, shortness of breath. You can often hear stridor. Patients can't lie back flat because it causes extreme panic. Distended neck veins, and then you get your collaterals on the chest wall and cyanosis. Now, this is always difficult, particularly if it's in a patient that hasn't got a cancer diagnosis, because you always want to know what the histology is first. Because if you go in with steroids and it's a lymphoma responds very well to steroids, it just goes, and so you won't be able to get a tissue diagnosis. But there are exceptions, obviously, if the patient is in extremis with central airway obstruction or in a coma because of cerebral edema, you just get on and give the steroids. But the histology also makes a difference as to what you can do to treat the patient, because if it's a very chemosensitive tumour, so small cell, lung cancer, lymphoma, germ cells, it's best treated with chemotherapy because they respond well and then your SVCO will actually improve. Others, though, you need to do different things. So obviously oxygen. We do a lot more stenting nowadays. That's the first line that we do. So they offer immediate symptom relief, and it also buys a bit of time then to get the diagnosis, to get the tissue diagnosis. I mostly give Clexane as well because there's obviously increase of thrombosis there. If you know the histology, dexamethasone, stent, urgent radiotherapy or chemotherapy. If the histology is unknown, and if you can get away with it, you just investigate first and get the histology. Often if it's a central line problem, you just leave the line in, because I've actually seen radiologists give local thrombolysis through the line and it actually dissolves the clot that's the cause of the SVCO. So there's different causes of it. Hypercalcemia is next. So this is actually a very common thing we see. 10 to 30% of patients have it during their disease course, and it's always important to maintain a high index of suspicion. Now, I was looking up, there's something I learned in the medical school, stones, bones, groans, moans, thrones, and psychiatric overtones, apparently, is the actual lingo here with what the symptoms are. So stones are, biliary renal stones, bones from bone pain, groans from your abdominal pain, constipation, which is quite common here, causing nausea and vomiting. Thrones apparently is polyuria. I didn't quite understand that, but maybe some. Oh, okay, yeah, maybe I do now. Thrones, no, THRO, yeah, sitting on the loo, right, got it. I did look at this last night. I was a bit late. And then psychiatric overtones. So we do see a lot of patients, depression, anxiety, panic, cognitive dysfunction, insomnia, and coma actually with this. So it's really important to find out what it is and then treat it. You always got to remember to correct calcium for albumin. I think I'd just get the patients in and get their calciums done and just get fluids straight away. The other thing, all at the bottom here, is to check the PTH, because you do see primary hyperparathyroidism, but it's not obviously common in patients who have widespread bone mets that are obviously turfing calcium out into their systems and making them feel very unwell. The mechanisms I've put here, so most commonly it's actually the tumour cells producing the parathyroid hormone releasing peptide, and that obviously stimulates the osteoclasts to come along and destroy all the bone and release the calcium. Obviously there's a bit of a vicious circle here. You can see that if the osteoclasts then produce tumour growth factor beta, which then stimulates the cells, and it goes round and round and round. Other things I've put up the top here. but really the management of this is the most important thing to talk about. Rehydration is really important, and so some patients actually, their calcium responds very quickly to giving them a lot of fluid, so 3 litres in 24 hours. I think if a patient's got a very high calcium, I probably would go in with the bisphosphonates a bit early. Historically, we've always used pamidronate, so that's given over 90 minutes. You give 90 milligrams if their renal function is normal. I have given 60 before if their renal function isn't as good. It lasts for about, maximum effect, is about 3 to 5 days, and it lasts for 28 days. So we often give them monthly, particularly with patients who are going through chemotherapy with bone mets. So you can keep adding in the bisphosphonate, and that's going to help strengthen the bones, control the bone lesions, and also help with their pain. We've moved over to zoledronic acid, which is quicker. It's given in over 15 minutes, so that helps in terms of getting many patients treated. But actually the new one I'm going to mention is the RANKL inhibitor. I don't think I'll explain exactly what RANKL stands for, because even I can't read my own writing at this moment. But we have, it's denosumab that we use, and it initially was licensed for breast cancer, but now it's been rolled out to all solid tumours except prostate cancer. I don't know why, there's not a nice guideline for that. So it's a subcutaneous injection that's given monthly, so that's brilliant for patients. And I think what we are potentially looking at with your agreement is whether GPs can actually administer this in the community, again saving patients coming up to hospital. It's all in the air, I think, at the moment. We do it here, and it actually can be given in the setting of renal dysfunction. There are some side effects. Patients can get profound drop in their calcium. So I've seen this a few times. So when I start patients on it, I tend to get their bloods done the week after just to make sure they're not dropping. But we also give the patients calcium supplementations to take daily alongside it. You can get flu-like symptoms, irritation at the injection site, but you can get osteonecrosis of the jaw. Now what that is if patients have got really dodgy teeth, okay, and they're on denosumab and they have a tooth extraction, the jawbone does not heal, and the patients are left with exposed bone in their mouth, which is really painful and really difficult to deal with. I always make sure that my patients have a dental assessment by the dentist, just to make sure they don't need anything doing before I start the treatment. Often people say, oh gosh, I haven't been to the dentist for about 15 years, and I'm like, well, I think it's worth doing it. And the other thing to say is, if the patients are actually on denosumab and they need something done, then you have to wait at least 8 weeks for the denosumab to get out of the system before then patients can actually have dental work. If that's difficult as well.
It's been a very good session. The sort of things I think I'll remember after today, after tonight's talk, particularly just some tips about prioritising for admissions for SVC obstruction, and also for neutropenia, and also for the cord requiner. It's just quite helpful to have a discussion amongst the GPs about who we would admit to, whether we go to the orthopaedics or to the oncologist, and I think it obviously varies in different parts of the county, but it's quite useful for the oncologist to be aware that sometimes we have difficulty getting patients in urgently, and just what those barriers are to admission sometimes. And so it just helps us to feel justified when we've got a clinical concern, knowing that we have to, blue light somebody, get them straight in, and approach the acute oncology nurse. And that's a new development which I think is very helpful to know about. Julie Cook, I think, having an acute oncology nurse who we can just pick up the phone and say, I'm worried about this patient. That's something which I'll hopefully be able to share with my colleagues at work.
I think the thing that's changed my practice after this evening's talk is, first of all, to know that Dr. Gorf is available for discussion, and that her role as a clinical oncologist is different to that of a medical oncologist, and what that actually entails. I found that really helpful. I also found it really helpful to know that there's a specialist nurse, oncology specialist nurse, that we can ring up, and that number is on the website that you've developed. Because often in general practice, and particularly out of hours, it's very, very difficult to know quite how to respond to certain types of problems. I also particularly found it helpful to know about some of the syndromes that I really hadn't encountered before, such as the tumour lysis syndrome in patients who have had hematological malignancies treated, and the pneumonitis that can occur at least 8 weeks after radiotherapy, because I really wouldn't have known about those until this evening, and also to have a refresher on all the metabolic problems that can occur after chemotherapy, radiotherapy, and all the other treatments. So I feel much more confident about the things I didn't know and how to recognise them now.
So the take-home message, I think, from this evening is that each patient's got to ring the acute oncology number as quickly as possible, and the GP will obviously know that each patient has got the number, so just ring and try and ring as early as possible just to prevent any complications.